There we go.
Perfect.
So, Dr. Hewitt, may I refer to you as Tim?
Please.
Please, and refer to me as Herb, because that's all I know. So, as I said in the introductory slide before this interview, we will have already shared with the audience who you are and some of the work you've done. But if you would, please share some of the highlights of your findings in your ACL research.
So I trained as a classic biophysicist, came out of the cardiovascular area. I really wanted to get into sports and sports medicine to do directly applicable research. One of the first studies that I did coming into the sports medicine realm was with the group I was with at Cincinnati Sports Medicine, looked at a place called Soccer World, where we had all the athletic trainers in Mason, Ohio, north of Cincinnati, and we covered all the matches there. Well, it was really an interesting study because it's relatively easy in injury epidemiology to get the numerator, who's injured, but it's pretty difficult to get the denominator, the total exposure. And I can tell you this, exposure is critical. And we were talking about this before. The more you expose yourself, the more your risk is. That's just simple mathematics. So the good thing is there were in both indoor and outdoor soccer, so they had equal number of grass fields, and at that time, the old plastic AstroTurf. And the theory that our surgeons wanted to test was they thought there were more ACL injuries happening on AstroTurf than there were on natural grass. So we had hour-long games, and it was interesting because everything was co-ed and you had to have an equal number of men and women. After an hour, the game was up. We knew exactly the amount of exposure of every athlete. Well, we looked at the data, and there was no effect of AstroTurf. Now, by the way, the new rubberized turfs are very different. They're very sticky, and the NFL's done a study showing about a 62% increased risk of an ACL tear in the NFL on these rubberized turfs versus grass. But you don't see, I think only one team switched back to natural grass, which doesn't make a lot of sense.
The Packers, did they stay?
Yes, yeah, but most kept their, it's a money thing, easier maintenance. So, however, when we looked at that data on the old plastic turf, the AstroTurf, there was no difference. And what fell out of that data set, which was really interesting, was that women per exposure were 6.2 times more likely to tear their ACL than men. And, you know, just as with everything in the literature, you think, wow, this is a brand new finding. No, it's because it was also very controversial at the time, still controversial in some contexts today. So I went looking, the first thing you do, you got to go looking through the literature and see who's already done it. Well, found in a very esoteric journal of the Southern Orthopedic Association, lead author Terry Malone, who's since I've become good friends with. I was just at this ICUS meeting with Terry. We've lectured together for the last 20 years. He found, he looked in the Big Ten and the Pac-10 in men and women's basketball. He found a 6.18 times more likelihood. So that's when you know you've got good data, when there's a consilience, when those data points come together and you find the same thing in a totally different population, totally different study. So that led me into an odyssey that has lasted more than 25 years. I hate to date myself, trying to figure out, number one, why that difference exists, what we can do to reduce that difference, and then downstream, how can we make outcomes better after those injuries happen?
Right.
So that's been the focus of my career for the last 25 years. I'd say the highlights that have come out of that is we were the first to look at neuromuscular control in male and female athletes and show differences that come down to neuromotor dominance patterns And then what we did is we designed interventions to directly address and target those deficits and imbalance in higher risk athletes, and showed in a study in the late 90s that using that targeted intervention, we could reduce the risk of overall all ACL injuries in all athletes by half, and reduce the risk of non-contact ACL injuries in females, women, and girls by 2/3.
Which is pretty close to that of the males, is what I recall. from some of this
Yes.
early work
So,
that we did.
the risk becomes very similar, not statistically significantly different.
Right.
So that's been the impetus and the drive for the work. And we, with Kate Webster, who's based out of Melbourne, Australia, who's an expert in the art of systematic review and meta-analysis. She won the award at this current AOSSM that we're attending here in Nashville this week. We demonstrated using a meta-analysis of a meta-analysis. So we did a meta-analysis of all the meta-analyses in the literature. We'll call that a mega-analysis. The real word for that in a Cochrane review, by the way, we didn't just make it up. It's called an umbrella review. And so this is more than 20 years later, based on more than 15 meta-analyses of the existing literature. What did we find? That you could reduce the risk of all ACL injuries by half, and reduce the risk of non-contact ACL injuries in women by 2/3. So again, consilience of data sets, when that all comes together and it shows you the same data, that's when you know that data is real and true and valid. And those have been, I'd say, the highlights of my ACL career. Now, where we've gone since that, together with several groups around the world, is trying to figure out, once you have one ACL injury, what is your risk of having a second ACL injury? What we noticed from the epidemiologic data, so we published this based out of our cohort at Cincinnati Children's Hospital, which is greater Cincinnati area, including northern Kentucky, that region. Basically what we showed is if you were young, physically active, and going back to the same level of sport after your ACL tear, your risk of another ACL tear within 2 years is somewhere between 1/4 and 1/3, which is just absolutely unacceptably high. There are many factors that go into this, and we've been sorting out those factors. Now, we published that back around 2010, and very soon after that, Kate Webster and Julian Feller, again out of Melbourne, Australia, literally the other side of the globe, 10,000 miles away, showed the exact same numbers, So in a much larger cohort. So again, consilience of data sets, that's what we know is real and true and valid. Your risk, if you're young, physically active, going back to the same level of sport, post-ACL injury, your risk of another ACL tear, either on the graft side or the contralateral side, is between 1/4 and 1/3, way too high. So basically where I'm going with the remainder of my career that I have left is to try to study and prefer to solve two problems. This problem of AMI, which is arthrogenic muscle inhibition. Once someone tears their ACL, for example, the most obvious aspect of AMI is your quad just shrinks and atrophies very rapidly. And part of what I think leads into this higher risk. And that's where we're going with our studies, multiple trials, biomechanical assessments, and I'm collaborating with people all over the world trying to figure those two problems out, because there's such severe debilitating problem that I had at one time in my lab at Cincinnati Children's Hospital. I had 6 staffers who had suffered 2 ACL injuries.
Same leg or?
A mix. Most of them were bilaterals. It's actually, you have a higher risk of a contralateral ACL tear if you're young and active than you do tearing the graft, because you load the opposite side a lot more. And so I think most of them, I'd say probably 4 of them were bilaterals and 2 were same knee at that time. Now, that first ACL can mess with you psychologically. There's no doubt about it. A second ACL, and very often they happen very soon after you return back to sport. That's when your highest risk time frame is. That really gets to you psychologically. And Kate Webster and Julian Feller and I and others have looked at the psychological aspects of this, and they are severe, they are long lasting, and they also predict risk of second injury pretty well. So the psychological aspect is a big player in this. So again, why did I have 6 staffers with 2 ACLs? Because that second one gets to you in your mind to such a degree that you want to figure out why it happened so that it never happens to you again, and you want to make sure that it doesn't happen to other people as well, just because it's so traumatic, so debilitating. I mean, you go through, 6, 9, 12 months of grueling surgery and rehab. You get back on the field, and a month or 2 or 3 later, you tear that, either your graft or your other side, and you are, this is devastating, depressing. You become fearful, anxious. There's so many psychological aspects to this that have been worked out, but need to continue to be studied.
Okay. On that last point about the fear and psychological aspects, have you delved into or noticed a psychobiology, i.e., as you said, sometimes we compensate more with the good leg, which then becomes at higher risk. Is there any piece to that puzzle?
Yes, absolutely. So we've done a series of studies where we used what's called the ACL RSI, again, developed by Kate and Julian in Melbourne, Australia.
What is RSI again?
The ACL RSI, the ACL Return to Sport Index. So that is a well-validated psychological assessment tool looking at psychological parameters and aspects to returning athletes as they're returning to sport. Really amazing scale that was put together by that group in Melbourne. So why Melbourne? Well, Australia per capita has the highest number of ACLs in the world of anybody by far. Now, why is that? Australian rules football.
That's what I was thinking too. That is one bad.
So what you have is they have these things called speckies, which is like a spectacular catch. You go up, you grab the ball, and you've got people knocking your body side to side, and you're usually landing on one leg. So let me show you what the injury mechanism is for an ACL injury. You basically land, and your trunk goes lateral to your knee joint. So what you have is a ground reaction force, multiple times your body weight, especially if you've gone up for a specky, you just jumped as high as you can possibly jump. So you're landing maybe, and you get jostled. So your trunk is gonna be knocked lateral to your hip and knee. And you're landing probably on one leg in the range of 5 to 10 times your body weight, because you've got your body mass and you've got your acceleration, and that's boom, bumping up the force, multiples of body weights. And once that center of mass moves over lateral to the center of the knee joint, so you have a ground reaction force reacting from your foot. Now, I should say, the foot's usually slightly internally rotated, the foot is usually externally rotated, and it's away from the center of body mass. And so you have a ground reaction force, and the ground reaction force from the foot is reacting here, is just about your umbilicus, where your center mass is. Well, if that ground reaction force goes lateral, because your trunk's moving sideways and your hip and knee are being forced inward, you have a torque, a valgus torque, or what we call in biomechanical terms
a knee abduction moment. What's abducting is the distal tibia that is extremely high, can be in excess of a couple hundred newtons, pushing your knee in. Now, that's what the foot looks like next to the leg and the trunk. That's the body habitus, the whole body picture. But then once we go down, just looking at the knee, what is happening as your body is doing this, from landing from a specky and somebody's jostled your trunk? We call that that's not necessarily a non-contact, it's an indirect contact injury mechanism. It's not a direct load to the knee.
Right.
Now, if you say if it's going to have to be contact or non-contact, it's non-contact because it's not a direct load to the knee. But if you want to get more precise in your injury mechanism definitions, it's indirect contact. There's contact body to body somewhere else, usually almost always the trunk, that leads to loads here at the knee. And here's what's happening at the knee. So if this is the outside of the knee joint, the fibula, you've got 3 rotations that abduction force at the tibia is causing. It's causing the knee to drop, the knee and the hip to drop in medially. Tibia is abducting distally. You're getting anterior translation, primarily of the lateral compartment. You're kind of pivoting around the MCL. And then what you're doing is internally rotating at the same time. And when all those 3 things happen at very high force, pop, you hear the pop very often, and your ACL is ruptured. So that's the biomechanical layout of how this occurs. But there's neuromotor consequences to this. So your ACL is this big. The ACL is proportional to the size of your pinky. Maybe perhaps a little bit shorter, but in diameter, it's about the same thickness. By the way, your PCL is the size of your thumb, your posterior cruciate ligament. And where they cross in 3-dimensional space, say from the sagittal, the side plane, is the center of rotation of the knee joint, where that ACL and PCL cross. But you can see the PCL is a bigger, thicker ligament. It's not going to go as fast as the ACL is. Plus, most of your forces during deceleration are coming forward and are pushing they're doing this. They're pushing your tibia forward and internally rotating, abducting. And what you get is this combination of load on the ACL that's higher than its load capacity, and it ruptures. Well, this ACL is not only this highly elastomeric tissue. So what it takes is, we did a study, Ed Grude, and a whole number of colleagues did several studies where we showed if you pull the knee joint apart, this takes about in the range of about 2,000 of newtons of force to rupture, 1,800 newtons, which is about 500 pounds of force. So this is a very tough, strong tissue. Now in New York, Pete Torzilli's group did a similar study, and they came up with about 2,200 newtons. In New York, even cadavers are tougher than everywhere else in the world.
You have to be.
Of course. So that's about 550 pounds of force. And so this is a very strong, very highly elastomeric tissue. However, it's not just something holding your knee joint together. It's full of mechanoreceptors. It has all 5 kinds of nerve endings in it. And what it does, it sits in the center of the knee joint. So the ACL is actually here, but I'm not going to use that as a model, obviously. But it's this size. It's full of all 5 types of mechanoreceptors, and it senses in 3-dimensional space the position and the forces acting upon the knee. And what it has is spinal level, afferent through the spine, efferent feedback loops that protect the knee joint and hold it together. So it's a sensor. Now, what happens is when this sensor is shredded apart, it basically looks like mop ends. It's like this, usually. Sometimes there are partial tears and there might be some fibers held together. Mechanically, it's not doing very much, but usually it's blown apart. And the electrical analogy I use is it's basically a fuse that's blown. The old-fashioned fuses and fuse boxes. That wire, that connection is exploded apart and it's separated, and you have an open circuit. Now, what happens in the nervous system when you have an open circuit is that the afferent runs an on signal. It says circuit's on all the time. What happens is that on signal goes through the spinal cord to the inhibitory interspinal neurons and turns them on, and they turn on and they shut down, they turn off the efferents. So then what you get is this lack of signal back to around the knee musculature, and the quad just shrinks. We still haven't figured out how to solve this problem and how to prevent it from happening. There are lots of ideas. One of the things people are doing now is blood flow restriction training to try to really intensely activate that quad enough so it doesn't atrophy. I was putting a list together the other day, and I came up with 12 different interventions that people are currently trying. Whether we put them all together and we could reduce by 70–80%, but there's still an aspect of it, that neural component where that circuit's open. Now, I think.
And by the way, a replacement for ligament does not reconnect that circuit. All that is just a piece of rope.
It does not. So what you're doing is the reconstruction of the ligament. What it's doing is it's taking a piece of tendon. So they're either going to take the patellar tendon, this part from your distal kneecap down to your tibial tubercle. They'll cut about a 10 millimeter or 1 centimeter piece out of there that's about 2.5 centimeters long. Either that, or they'll take your medial hamstrings, which I think is a big mistake, because what that afferent feedback loop is, it turns on your hamstrings. And what do your hamstrings do? They can externally rotate, posteriorly translate the tibia. You need that. So to take out that neuromechanical protector of the ACL and of the knee joint, I think is a big problem. So the other option, which I really like, which at AOSSM this meeting they talked about a lot, they're showing really good results, are quad tendon grafts, or from a cadaver. Cadaver, which is called an allograft, the others are called autografts. They're self. Auto is self. Allo is other. It's from a cadaver, another person. Really bad idea in young, active people going back to sports. You wouldn't want to put an allograft in a high school, soccer player. I think in a female high school soccer player, because females tend to be quad dominant, but they also tend to be, when they turn on their hammies, they tend to use lateral hammies. Now, lateral hamstring activation, when you tighten this side up, what happens? You internally rotate, and you go into a collapsed valgus position. So you really need these medial hammies, especially in that population that underutilizes those hammies, and especially the medial hammies relative to the quadriceps. So again, another reason I think using medial hamstrings is a mistake. But what you're doing is you're taking a tendon and you're putting it in there, and what it does is it undergoes a process called religamentization. Believe it or not, the body sees that in the knee joint, and it attempts over time to turn it into that tendon tissue into a ligament. Now, is it reinnervated? There's been mostly studies done in most of this data is old. It comes from the 80s and the 90s. Most of the studies were done in dogs. There's been some done in rabbits. There's no evidence that you get any neural reintegration into that graft. There was a study of one guy, he was in Norway, undergoing that long Norwegian winter, couldn't take it anymore, committed suicide, and he was about 18 months out, and they took the knee joint and they sent it off to Vermont, one of the labs that could really look at innervation, and they saw no reinnervation at 18 months of that graft in a human being either. So even if you did have some neural reintegration, it takes such fine calibration and precise neural activity that it probably wouldn't be the same, even if it did occur. So I think what you rehab professionals, trainers are doing is, you've got this blown open circuit that isn't coming back, whether you don't reconstruct or whether you reconstruct. And I think what people are doing, and I need to write this idea up, I haven't written it up. If anyone wants to write the paper with me, let me know. But I think what you're doing is developing parallel circuits through the fascia, through the musculature, through tendinous tissues, parallel circuits to sense the position and the force loads on the knee joint so that you can, and it has to be at a spinal level, react. There have been many new studies out on fMRI showing that post-injury and then post-surgery and then post-rehab, you've got fMRI changes in brain activity. Well, that's obvious, that's gonna happen. And they say, well, that's what this is related to this ACL injury. The problem is fMRI is a very inexact, imprecise science at this point. And what contributed to those plasticity changes in the brain? Was it the injury? Was it the surgery? Was it the rehab? Was it numerous other things, psychological issues with the injury itself? We can't at this present tease that out. And I think the circuits that have to be developed have to be spinal level, just like the original is, because it has to be very rapid. An ACL injury happens within the first 30 to 50 milliseconds of the foot hitting the floor. To go up even to your brainstem takes in the range of 120 to 150 milliseconds. It's too slow. You have to have spinal level loops to actually protect, sense, control your knee joint. And I think what rehab professionals are doing over time is developing parallel circuits. That circuit's not coming back. So they're developing parallel circuits to sense and control and unload that knee joint. Now, here's the big problem with all this, is development of even parallel circuits takes quite a long time. So we wrote a paper just a couple years ago that questioned, should athletes wait 2 years after an ACL injury to return to sport? We took a lot of flack for that, very controversial paper. For one thing, it was a bit tongue-in-cheek, it was a bit rhetorical in what we were asking. So I sat at an AOSSM meeting, just like this one here in Nashville. It would have been back in about 2007. And I was just noticing, I was taking down notes as I was listening to every talk. And then I looked at my sheet and I picked out of all my notes, there were 8 different points where I realized, man, things post ACL don't come back to significantly similar to baseline or to a control population until about 2 years. So whether you look at any crude measure of, say, joint proprioception, like a balance test on an unstable platform. Or if you look at something like bone scans, that joint is very hot. It's metabolically very active. It doesn't come down until about 2 years.
Come down to zero, or is
Or
there a
it come
point where-
down to, you can't tell the difference. It's usually compared to the other side, usually, which is not a very good comparison. Now, why is that? Well, your body always moves, always controls itself with the most efficiency possible, the greatest efficiency and economy. So what you have is a injured, perhaps reconstructed knee that has significant neuromotor control deficits. What do you do from a spinal level adaptation? Well, you can't bring this one up for quite a long time. So what happens over that 2 years is you get adaptations, and the adaptations you get are on your other side. Your other side drops down similar deficits
Try to get bilateral.
to get bilateral economy
Yeah.
of movement. Well, that's obviously a big problem. So
So it's
now,
not just a function of strengthening that leg, getting more strong because of the work we're doing in rehab. It's really that it's coming back to the level.
yes, and it's really important that you're rehabbing the opposite side in the same way. And it's not a very good, it's the control that we all use, our baseline that we compare to, but it's reduced as well. So you're saying, okay, now we're getting at 2 years out, we're getting similar to baseline. Well, the baseline's already, it's already in deficit. So you've got problems with that concept as well. So what we usually do in our studies, we compare to the contralateral side, but we also compare to a very match. So we ask our athletes to bring in it's usually one of their best friends, same age, same sex, same height, same weight. It's usually a same position player off the same team. And that way we can study them and compare to someone who's healthy, who hasn't had an injury. Better yet, in our forward-moving prospective cohort studies, we have data on the person before they get injured. That's even more critical. That's a better control, obviously. So what you see is these deficits. Now, what are these deficits? They're actually similar to the deficits in these prospective studies that we do, these prospective cohort studies that we do and follow people before they get injured. So what are the deficits that lead into injury? Well, there are at least 4 basic ones, these neuromotor deficits that increase your risk of a primary ACL injury and increase your risk of a secondary ACL injury. And then we add on the psych factors along with to that for a 5th factor. So ligament dominance is a neuromuscular imbalance that is highly problematic. What do I mean by that? Your neuromotor, especially your muscular system, is underactivated, and you're using, instead of using your musculature, especially posterior chain musculature, glute, whole glute, hip complex, quads, hammies, calf, activate on landing, on cutting to absorb and dissipate those ground reaction forces we discussed. Instead, you're letting the ground reaction force push that hip and knee where it wants it to go, medially collapse it until it hits that ligament, and you're using the ligament to control that force. Well, the muscles are designed to control and dissipate force. The ligaments are not. That's not what they're there for. They're there to hold the joint together. Well, the musculature can absorb a whole heck orders of magnitude more force than a ligament can.
Yeah, I
So-
don't know for a second.
Yeah.
Because when I first started encountering your presentations at conferences, you spoke of ligament dominance. And one of the things, at least at that time, was that many female athletes stand in a genu recurvatum position, suggestive of the possibility that that's what they're hanging on
It
to.
creates ligament dominance. basically the idea is very often these young athletes will literally, I mean, you've seen it, anteriorly tilted pelvis, recurvatum, just, you know, instead of this position. So the first thing you're gonna do as a trainer is get an athlete into this position. Balls of the feet flexed. Flexed hip, trunk extended, shoulders back, good postural control, ready to react, ready to dissipate force in all planes. This is a muscle dominant position. This
Right.
is a ligament dominant position.
And for those who can't see, because I do have a little bit of recurvatum, right? It's going beyond the line of the hip and the ankle, right?
Exactly.
So and he's wearing long pants, you can't see that as well. But it's that idea that the knee, and young women in particular, have that ability to hyperextend.
I apologize for, luckily Herb has sexier legs than I do. I should have worn shorts. So that's the first neuromotor imbalance that we first discovered and published on. The second one is quadriceps dominance. So quad dominance, your quads are an important muscle, very strong muscle, not as strong, not as powerful as the glutes. The glutes are the biggest, most powerful muscle in the body. The quads are big, strong, powerful muscle. There's a couple problems with being quad dominant. Quadriceps, if you're in less than 45 degrees of knee flexion, if you fire up the quadriceps pulls your tibia forward and strains the ACL. That's called an ACL antagonist. It puts strain on the ACL. Whereas the posterior chain musculature, the hammies, are a ACL agonist. They help the ACL. They pull the tibia back because what the ACL is doing is restricting that anterior and internal rotational torque on the knee joint so that the hammies take stress off the ACL, whereas the quadriceps put stress on. Plus, if you're at a relatively extended position like this, and you're contracting your quads, here's what's happening. Now, does your quad pull the joint together? Yes, it does. When you activate the quad at full extension, when very often you're landing like that and cutting like that, very near full or even some slight hyperextension, yes, the quad is pulling the tibia and femur together, but what happens is due to the shape of the medial and lateral tibial plateau, so the lateral plateau is convex, it's like a bubble. The medial tibial plateau is concave, so it's an indentation. So what happens is you tend to get a rotation so the medial femoral condyle fits into that hollow better, and this is round and convex, and it causes this. So when you put a lot of quad activity, you're reproducing that injury, that valgus anterior translation internal rotation that tears the ACL. So what we realized is we have to make athletes less ligament dominant, more muscle dominant, less quad dominant, more posterior chain dominant. And then the third one is,
Before you jump on that, you found in the early days at least that there was a gender bias there.
yes,
Females were more quad dominant.
absolutely, females are more quad dominant, and that's been shown, again, consilience of the literature, whether you've looked at it with biomechanics or EMG or any kind of video analysis. What you'll see is, on a Biodex, muscle strength, at high speed, what you'll see is females are more quad dominant than males, as they are more ligament dominant, yes. And that's not true of just females. It's true of any athlete who's at greater risk of an ACL tear. Some really high level male athletes, professional athletes that we've studied, are very quad dominant. Why is that? Well, their sport, their position requires huge, powerful quads. So the people who are at risk are people like running backs, people like defensive backs, people that have very often even squatted a lot, but they become really front loaded due to their position. And very often sports, this is why professional athletes, you do the same thing, the same skill, and you're looking for skill and performance. So if you want the most performance out of your quadriceps muscle, what do? You inhibit your hammy, because you're going to get more force out of it because the antagonist of that muscle is shutting down. So over time, many great athletes, high level athletes, pro athletes are creating more muscle dominance to perform better.
And this is not just a strength ratio.
It's not just a strength
It's a
ratio.
firing
It's
pattern.
very often a firing pattern related to the skill that they do over and over and over again that's making them better and better and better at that skill. But very often it's putting them at greater and greater and greater risk. That's why pro athletes, for a few reasons, neuromotor imbalance, basically from repeated skill training and huge levels of exposure. And again, going back to the idea, one of the biggest factors is how much exposure you have, and they have a whole lot of exposure, obviously. But they're putting themselves at great risk, and many great athletes are quadriceps dominant. Third, leg dominance. Now, we all have some level of leg dominance, right? Use one leg. Most people are going to use one leg to kick a ball. The majority of people are right leg, right hand dominant. But what we see in athletes that are at greater risk, whether it's a female athlete, and we see this more often in female athletes, but all athletes that are greater risk of injury have greater difference side-to-side dominance patterns. The more balanced you are side-to-side, neuromotor, strength, from any aspect you can measure, the more you are balanced side-to-side, the less risk you have. You're not going to load one side differently than the other.
If I may. So we're speaking to a lot of trainers here. Most trainers are going to hear that, meaning that we need to do more right leg, more one leg exercises in the weight room, and presume that doing so creates symmetry. But what I hear you saying is it's not simply a strength issue. You can't do the same weight on the knee extension machine and say, oh, see, you're symmetrical.
Yeah.
We need to condition closed chain circumstances
Yes.
to make them symmetrical. How can a trainer do that?
Well, you start out closed chain, double leg, then you progress to open chain and closed chain, single leg exercises, and then you bring yourself back to double leg exercises and make sure you're measuring in as many ways possible, not only strength, but balance and proprioception and control, however you can measure neuromotor control with performance indices, hops. I mean, nothing's perfect, but start out whole, part, whole, and make sure when you're going back to whole that your part, you're creating symmetry using your part training so that when you go back to whole, that you've got symmetry when you've got both feet on the ground.
Cell phone technology has really helped us with that.
Yes.
I can video in slow motion and see the movements.
Absolutely. So that's a crucial aspect to it, is leg dominance. And the other pattern that we saw in people at great risk was trunk dominance. And what I mean by that is athletes who are at greater risk land and cut, and they start with their trunk more upright and they finish with their trunk more flexed. So we first published this and we said, these people have more upright trunk. That's what we saw, the people that go on to a second injury. And then another group, using a slightly different test, said, oh, the trunk is more flexed. And we looked at the initial point, the first 30, 50 milliseconds where you're expecting injury, and they looked out through the whole stance phase, the whole landing phase. So that what we figured out when we looked at both of those, again, the consilience of the data sets, was we were both right. They're more upright at the beginning of the movement, and then they go to more flexion, which means there's just more out of control trunk movement. And especially, so that happens in the sagittal plane, but also in the frontal and transverse plane. There's just, you have less control at your core, therefore you get more full range trunk motion in all planes. So how do you deal with that? You can start out again, start out whole part whole. You go and do core type training exercises on your feet. You can break it down, come off your feet, focus on that core, go back on your feet again, and make sure you have good core control and that you don't have excessive trunk motion when you're landing, cutting, or in these high risk positions.
Well, and that brings me to one of the questions that I had for the overall lesson here. Many people, even though we use the word core too much in many respects, still identify core as from the hip bones up. And when you define it, you're including
I would,
with style.
what I would say the core is, simplest definition I can give you is every muscle attached to the pelvis is your core. Because what you're doing is you're using that much musculature to control the pelvis.
Right.
So any musculature attached, so you're talking pits, the knees.
Right, right.
Mhm.
And then you identified one of the features that I'm really keen on, which is core work in the upright posture or the standing position, both bilateral, 2-leg and 1-leg. And that takes us off the floor a little bit, because right now, a lot of trainers still are stuck in the 70s, 80s models of crunches, and then they've converted to planks. Planks are good, but football players don't get hurt doing planks. They get hurt when they're running. So what type of moves, exercises can a trainer think about? And I'm familiar with some that I've heard at conferences.
Well, again, so break it down, you start with simple 2-foot on the ground plyometrics. So plyos are just a great exercise to power everything up. Then you can go to part and start isolating. I really like, there's a lot of data behind Russian hamstring curls. We use an assisted.
Some people call those Nordic hamstring.
Yeah, I think Russians were first. But I've been in this game a long time.
Start a war with this.
Yeah, well, the Vikings stole a lot of things, including naming the hamstring curls. So in the Russian hamstring curls with an assist, we actually use a band. We put their knees on a air pad. We very often will put a Bosu on their chest so they don't face plant, and then have a partner plant on their, hold down their heels, and then use a band assist to get the whole range. So not just the eccentric lowering phase, but the concentric phase as well. So you take advantage of that whole movement cycle. I really like those Russian hamstring curls with an assist. The second thing, I really like going to a single leg Romanian deadlift. Great exercise, start out light, start out with nothing, and then just add slight weight at the hands with dumbbells. Those are two of my favorites.
And to that point, and something that I think trainers miss, but I think what you've spoken about thus far that needs to be considered is it's not simply the performance of the movement. There's a qualitative element. In other words, if the knee is collapsing inward, if you're going into functional valgus or something like that, dysfunctional valgus, then just because you can get your body down low and come up doesn't mean you succeed. So we need to, correct me if I'm wrong, we need to be watching, especially if we're working with a knee athlete, looking for how they're moving on the ground, right?
Yes, absolutely. So then that's your part. Then you go back to the whole and you do higher level single and double leg plyometrics. If you haven't ever seen it, if you want to see a perfect Russian hamstring curl, look up Russian hamstring curl, Adam Archuleta on YouTube. The guy would do 2 45-pound plates, perfect form, no assist on Russian hamstring curls. I've never seen anything like it, but amazing feat of strength and neuromotor control from Adam.
Right, and now, next week, if he tears an ACL, everything you said.
He's out of the league now, so I think we're good.
That's good to know. So in that context, we've discussed what you might be doing strength-wise and work a little bit more towards the hams, a little less towards the quads, going from whole to part, back to whole, more dynamic with plyometrics. Is there a place and time for trainers to incorporate the balance devices, the RX pads, the foam rollers?
Oh, yes, absolutely. Use them. So those are, as you're training, those are also great testing tools. So time they can hold that, the amount of sway that they're under. And again, with videos on cell phones, you can, an iPhone can do amazing things these days. So yes, OSUs, AirX, wobble boards, all of that are great elicitors of these parallel circuits that you're trying to develop. So yes, I think those play an absolutely crucial role, and you can progress them out to, I've got many examples of plyos on and off of those unstable platforms. Again, pushing them out closer and closer to the field before they get back to sport. And I think, let me just say, I think trainers are the absolute crucial link in return to sport, which is the most problematic phase, because what happens is, in the vast majority of people that have ACL tears and reconstructions, is they have so many visits, say whatever, it might be 12, 18 visits. They're done at 4 months or 5 months, even 6 months. They're let go to like, see ya. I think it's so crucial at that point for a physical therapist, physician to hook up with a trainer who's knowledgeable in this area to bring them to full return to sport, which really, from a time standpoint, shouldn't be, again, time should not be the critical variable anyway. We all use it. It shouldn't be the critical variable. It's objective testing to make sure that athlete is not ligament dominant, it's not quad dominant, it's not leg dominant, it's not trunk dominant, bringing whole part whole techniques, getting them back to the point where they're prepared, fully prepared to get back to sport. That may not be till 2 years. And when I say that, people say, well, that's crazy. Well, I can tell you the data, for example, out of Australia and Aussie Rules football shows about half the people don't get back, about 48% don't get back until 2 years. So that's not a completely crazy idea. From a performance standpoint, most people aren't performing at the same level again until about 2 years. But if you're going to use time, if you're not going to use objective measures, which you better use them, minimum, I think 9 months. If they have some associated injuries, better go 12 months, because post 9 months, good data shows that every month you delay after that, you decrease your risk of a second tear by 10%. You don't want to have that second ACL tear. It is devastating. It's devastating for the surgeon. It's devastating for the physical therapist. It's devastating for the trainer. And then, of course, the parents are devastated. Of course, the coach is devastated. But then you've got the athlete.
The long-term sequelae of an ACL repair anyway.
Yes, it's just tremendous. The outcomes are not. After you have a second ACL tear, the long-term outcomes, OA, osteoarthritis, total knee, are really bad.
Yeah.
Really bad.
So a couple pointed questions that I'd like to wrap up. One is, in your experience, in your studies, have you found a role for foot angle control as far as both potentially linking to or causing or contributing to ACL injuries, and also how, if that's the case, how we need to work in that agreement?
So yes, foot angle control, again, that's where the force is coming from. So the first thing, what you'll see, I challenge anyone out there
to send me a video of someone who's torn their ACL that their foot isn't flat on the ground. What that means is you can tell that this is, again, when I'm talking about training and testing, have kids do plyos. There's a big difference between this, and that. Tell the difference? That's not just loud, it's massive forces going onto your knee joint. So the first thing is flat foot. So you want to focus on getting up on the ball of the foot. That's a crucial aspect of
More
this.
supinated position.
Yes, more supinated position.
Right.
So that's absolutely crucial, getting them on the ball of the feet, using their feet as a rocker. A lot of what you can do to cue these kids like this is soft landings, not loud landings, okay? So land softly. So what they'll do is they'll land on the ball. They do this subconsciously, by the way. You say, you know, I'll go out there and we'll be training a whole team of kids, and I'll say, you sound like Cabot. I mean, and they do when you start out doing plyos. Soften it up, kids. Soften it up. I do not want to. I used to write my grants in an office just off the training area. You know, I'm trying to focus on trying to get a couple $1 million worth of funding to do these studies that we're looking at these kids on. It's driving me crazy because they're just, you know, and I know what that means. So I go out and I just, hey, soften it up. It's too loud.
Tone it down. I've got one.
It's too loud. And immediate response. They land on the ball of their foot. They use their foot as a rocker, ankle control. I think the gastroc and the soleus are crucial muscles to develop, especially the medial side. And so, yes, absolute crucial role in this. Now, the way you get after that is listening, teaching soft landings, but then breaking it down to single legs and doing a lot of unstable platform, and make sure that they're keeping nice and tight in there. So when you have when you're balancing on a platform like that, you should have a figure 8 type pattern. It should not be too tight, too linear, or even too circular. It should be a nice figure 8 type pattern on balancing, because what is that going to do? That's going to activate all those crucial inverters, everters, supinators of your ankle. It's going to not only strengthen but elicit recruitment.
Well, I know when I've done rehab for my 3 joint replacements, one of the early phase exercises is to put you on an RX pad and see if you can balance.
Yes.
And because I know and I've read the literature, I'm aware of what I'm supposed to try to be doing. But a lot of trainers, I'm not sure, are aware that they shouldn't be counting the seconds so much as they should be watching the foot,
Yes.
because a lot of people will hang on in overpronation.
Yeah.
And they'll just lean to the side away from that to say vertical, but not linearly vertical.
So what you should be doing is, yes, counting time, do it, you know, and keep extending that out. You start out with 5 seconds, you go to 10 seconds, you go to 20 seconds. So you set your time. So that's your exposure time. That's a crucial one, but that's not the only thing. And as you just got at, Irv, you want to look at the quality of control of that movement. As I said, you want a figure 8 type pattern. Say if you've got it on a screen or an iPhone or something, you're looking at more of a butterfly type pattern at the foot. And then you really want to, if, for example, I think a good assessment so during a specific amount of time on a single leg balancing, whatever you're doing it on, a BOSU, a RX, a wobble board, on the floor, is touchdowns. So the way to test for it is number of toe touchdowns on the opposite side per time. So that's just a good, you know, relatively simple measure of control.
Great. And then I think the last piece is, and this is stepping backwards to the earlier part, but is there any evidence to show that the Q angle, 1, exists, and 2, has a role in ACL injuries, and obviously you can't repair that because it's based on the person's body shape. But are there exercises that we can do to fight against the effects of one? First, does it have a role in
So the
ACL?
Q angle is the quadriceps. So that's the angle of the extensor mechanism of the quadriceps. So the Q angle is basically from here, the center of your hip, to the center of your knee joint, to your tibial tubercle. So why the tibial tubercle? Because that's where the quadriceps tendon is acting to extend your. So it's true that women they have a greater Q angle than men. So which means they're more valgus. It's more like this. That's the Q angle. It's true that women have, but it's not by very much. It's when you look at a whole bunch of people, it's like a degree more of Q angle, of more valgus in that direction. There is some evidence. There was an early study out of Canada by Gray in basketball players comparing males and females, and they attributed a greater Q angle to greater ACL injury risk in women. There was another study out of West Point, obviously way more men than women in that cohort. Men, they only showed like 1 or 2 predictive factors, and women, they showed like 8 or 9 predictive factors, and one of them in women was Q angle. There's been 10 times that number of studies, probably between 15 and 20 studies that have shown no association between Q angle and ACL injury risk. You can't change it. That's an anatomical mechanism that you can't change. Again, I think you go back to the basics. You focus on making these athletes less ligament dominant, less quadriceps dominant, less leg dominant, less trunk dominant, more psychologically prepared, and you'll do the best you can for that athlete. Some things are unchangeable. I don't think an increased Q angle predestines an individual to an ACL injury.
Well, you've offered a ton of information. It's going to take a ton of time for the participants in this program to digest it all. I will hopefully have covered some of the anatomy and mechanics of an injury prior to them hearing this interview. But I thank you so much for everything you said.
It's been my pleasure.
I could spend hours more, but I've got the rest of the day too. Thank you so much.
Eric.
Yeah.